Hello everyone and welcome back to Regeneration Hub Pune. I am Dr. Nihal Devkar and in today's video we are diving deep into the management of multiple adjacent gingival recession defects commonly referred to as MAGR. Gingival recessions can pose both aesthetic and functional concerns, especially when it involves multiple adjacent teeth. In recent years, minimally invasive root coverage techniques have significantly evolved, and among them, the intrasulcular tunneling and VISTA techniques have shown promising evidence-based outcomes. In the first part of this video, I'll walk you through the surgical options available for treating MAGR, an introduction to the intrasulcular tunnel and VISTA approach, the basic principles of VISTA along with its advantages, indications and limitations, certain modifications, and a brief overview of scientific literature supporting the success of these techniques. In this second half, I'll be presenting a clinical case of multiple adjacent gingival recession managed using a combination of VISTA, intrasulcular tunneling, and a connective tissue graft, highlighting key steps, instrumentation, and surgical pearls from the procedure. So stay tuned till the end to gain a comprehensive understanding of these advanced periodontal plastic surgery techniques. Let's begin. Gingival recession is defined as a apical shift of gingival margin. It is among the most common type of mucogingival deformity. Compared to single or isolated recession, multiple adjacent gingival recession or MAGR is gingival recession in consecutive tooth sites. There are a variety of surgical options to treat these multiple adjacent recessions that include free gingival graft, coronally advanced flap, tunnel techniques with coronal access like intrasulcular tunneling, MCAT, or tunnel techniques with vestibular access like VISTA and pinhole. Most or all of these techniques can be clubbed with or without autograft, allograft, tissue substitutes, or biologics. In this presentation and the following surgical case, our focus will be on both intrasulcular tunneling as well as VISTA. As far as intrasulcular tunneling is concerned, it is proposed by various people including Otto Zuer and Sofia Aroca. In this article proposed by Otto Zuer, they have shown that tunneling resulted in significant better clinical outcomes compared with coronally advanced flap and resulting in significant root coverage gains compared to CAF. Another significant contribution in intrasulcular tunneling is by Sofia Aroca, who through various articles in 2010-2013 has shown the advantages of intrasulcular tunneling and named it as modified coronally advanced tunnel technique. In both these techniques, first step was to take a cellular incision using a microsurgical blade, and in the second step, tunneling knives were used to raise these gingivo-papillary complex in a full thickness manner without dissecting the papillae. So after intrasulcular tunneling, let's check for VISTA. It stands for Vestibular Incision Subperiosteal Tunnel Access. It was introduced by Dr. Homa Zade. It's a minimal invasive surgical approach which reduces patient discomfort and recovery time. It addresses majorly multiple adjacent gingival recessions with a single incision access, preserving the papillae. In the original technique described by Dr. Homa Zade in 2011, the first step was to put an incision at or near the labial frenum in the vestibule, and then after shifting to the use of various tunneling instruments to shift the gingival margin coronally using a subperiosteal tunnel access. After the coronal shift, the facial gingival marginal sutures were tied or anchored to the facial composite stops in the original technique. One can also use interdental composite stops to hold these sutures. So, The basic principles in performing VISTA techniques are: first, to give a remote access incision which is made in the vestibule away from the recession sites. Next, to extend these incisions using a subperiosteal tunnel under the papillae without any surface incisions. Next, one can insert variety of graft materials under this tunnel. And finally, to achieve a coronal advancement and anchor them to the facial composite stops. The advantages of VISTA techniques are: it's minimally invasive because there are no vertical incisions made over the papillae. There is better blood supply because the papillary architecture is preserved. So there is enhanced aesthetics since there are no visible scars and a better color match. There is comfortable healing, less post-operative pain and faster recovery, and it is ideal for recessions, especially in the anterior zone. The indications for both intrasulcular tunneling as well as VISTA are almost similar, which are recession cases of Miller's class 1 or 2, then recession types, that is multiple adjacent gingival recessions, preferably in the aesthetic zone, but both can be done in posterior areas as well, and especially for VISTA when there is sufficient vestibular depth. The contraindications for these techniques are: shallow vestibule when there is limited space to insert the tunneling instruments, then there can be presence of bony dehiscence, poor oral hygiene where patient cannot maintain the hygiene post-operatively. Also, lack of experience can lead to complication and failures, so the operator needs to practice few surgeries. After the original technique of VISTA, there have been a lot of modifications proposed by various authors, which include modifications in the incisions, that is number and location of the incisions, or use of certain biomaterials like collagen membrane, bone replacement grafts, soft tissue grafts, platelet concentrates, chorion membrane, non-pedicle buccal fat pad, or use of the gold standard connective tissue graft. Let's check some studies related to VISTA. Fernandez in 2023 compared modified VISTA and coronally advanced flap and found no statistically significant difference regarding the mean root coverage achieved in the treatment of multiple Miller's class 3 or RT2 recessions with both surgical techniques. Results, however, favored modified VISTA considering not only complete root coverage but also other periodontal parameters like recession depth and clinical attachment loss. Another study by Matvijenko in 2024 compared tunnel and modified VISTA. Both methods were effective procedures for treating multiple gingival recessions of RT1 as well as RT2 recession cases. Tunnel technique on one hand showed superior outcomes in keratinized tissue width, cal and recession depth, whereas modified VISTA reduces gingival recession width. Another study by Chen in 2022 used VISTA and tunnel technique along with connective tissue graft to treat RT1 multiple gingival recessions. Both techniques were found to be effective in achieving root coverage. VISTA plus CTG had slightly more scar formation, whereas tunnel with CTG were better in aesthetic outcomes. Let's go ahead with our case. A young male patient complains of sensitivity with upper and lower back teeth. On examination, there is gingival recession with premolar area in almost all the quadrants. As you can see, there are buccally placed 1-4 and 4-4. There is slight malocclusion. Patient is not willing for further orthodontic treatment. Our focus is on the first quadrant since the patient complains of more sensitivity here. There is RT1 recession. There is association of multiple buccal freni. The keratinized tissue appears adequate, while the gingival thickness, it is thin. The periodontal biotype is thin and scalloped. With the graduated probe, we notice that there is average recession depth ranging from 1 to around 2.5 millimeters. The treatment plan for recession with 1-2, 1-4, 1-5 includes start with phase 1 therapy, where we do scaling, root planing, shift the patient to ultra soft toothbrush, and then after the surgical options is to combine both the techniques, that is VISTA Intrasulcular Tunneling, and since the gingiva had a thin biotype, we thought of adding the connective tissue graft. For the surgical procedure, here is the layout of the surgical instruments, which includes basic diagnostic instruments, BP handle, 15 number blade, some microsurgical blade, also a set of tunneling instruments and set of tunneling knives. In addition, we have Castroviejo needle holder, Castroviejo scissor, tissue forceps, resorbable suture for connective tissue graft into the tunnel, and some non-resorbable suture for closure of the donor site. Here we are using the interdental composite stops for anchorage. First, the local anesthesia infiltration is given. Then after using a 15 number blade, we give a vestibular incision between lateral incisor and the first premolar. Then after we switch to the microsurgical blade to start with the tunneling procedure to break down the fibers. And since we are combining both VISTA as well as intrasulcular tunneling, we use the same blade to incise through the sulcus. Here we are doing the intrasulcular tunneling for 1-2 from mesial to distal. Then after we shift to the tunneling knives or tunneling instruments, and we try to shift the entire gingivopapillary complex coronally. One can shift or use variety of tunneling instruments as per the osseous architecture underneath. We are shifting to the next tunneling instrument here. The path is created using the vestibular incision. So insertion of the next VISTA instrument into the tunnel and releasing the fibers, full thickness coronally and partial thickness apical to the mucogingival junction. The next instrument, a sharp one, double-ended. This is the other end. So we insert this instrument now through the VISTA tunnel, and after the insertion we break down the remaining fibers to create a uniform path or single plane of insertion for the connective tissue graft. So using a micro tissue forceps, we check the release of the flap. It's good for lateral incisor as well as the second premolar. Some tissue still needs to be released at the first premolar level. So we use the tunneling knives now, especially around the papilla between the lateral incisor and the first premolar, to cause a full thickness raise. Also at the second premolar area, tunneling is done beyond the distal line angle of the second premolar, almost reaching up to the mid surface of the first molar. Also on the other side, that is beyond the lateral incisor, reaching up to the mid level of the central incisor, tunneling is done. And once that is done, we again confirm the release, and now we shift our focus to the palate to harvest the connective tissue graft. In this case, we are going for the harvesting of free gingival graft, and later on we are going to de-epithelialize it. So the marking of the site of the connective tissue graft is done, and then after using a fresh 15 number blade, we start the harvesting of the free gingival graft from the apical area towards the center, trying for the uniform thickness of around 1.5 to 2 millimeters. One can do the intraoral deepithelialization using burr, and once the tissue is harvested, we confirm the thickness as well as the length of the graft that is obtained. For the palatal donor site, we need to achieve the hemostasis. So here we are using a collagen hemostatic fiber in the form of hemocol, which is available in these vials. Once the vial is opened, the required amount of the hemostatic fiber can be kept ready. To achieve the hemostasis, we can keep the fiber and wait till the suturing is done with the connective tissue graft. For the deepithelialization, we can also do it extraorally using the 15 number blade. One needs to confirm that all the epithelial portion as well as the fatty as well as the glandular tissue is carefully removed to achieve a uniformly thick connective tissue graft for the insertion into the tunnel that is prepared. After the CTG is ready, we need to confirm the extent of the CTG. So it's placed on top, and now we are planning to get the CTG inside the tunnel and place the CTG over the premolars. So the initial starting point is from the premolar exit through the VISTA tunnel, then passing through the connective tissue graft, going back from the tunnel and follow the same route to get the connective tissue graft inside the tunnel, and the final exit of the needle distal to the second premolar, and then after using the probe as well as the tissue forceps, we try to insert the connective tissue graft inside the pouch that is created on the tunnel. Once that is achieved, we can put a knot onto the distal aspect of the premolar. In a similar manner, the graft can also be secured on the mesial side to have the extra stability for the connective tissue graft. After stabilization of the connective tissue graft, we need to suture the flap. So one can use variety of techniques like sling and tag, or sutures like belt, suspender sutures. In this case, we are using suspender sutures which are anchored over the interdental composite stops. The vestibular incision is also sutured. For the palatal donor site, to prevent any secondary oozing, one can reuse the hemostatic collagen fiber or any other biomaterial and cover it using an acrylic plate if needed. The fiber can stay on the donor site. This is the comparison of pre-operative and immediate post-operative picture. The recipient site sutures can be removed after around 2 weeks. So, in a nutshell, both VISTA as well as intracellular tunneling, when combined with connective tissue graft, is a clinically effective and minimally invasive technique. It gives excellent aesthetic outcomes, less discomfort, and gives stable long-term results. And it is ideal for multiple adjacent recession cases, especially in the aesthetic zone. Thank you all. See you soon in the next video.